This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
Hey guys, Dr. Lynch here. Today's Medical Minute, I want to do it in the form of a case. So let's start off. We have a 52-year-old male who's come in. He slipped and fell while he was in his house. And as he went down, he hit his chin on the table, causing his head to be hyperextended backwards. So he shows up, C-collar in place, C-spine precautions, and we'll kind of jump to his neuro exam because that's the interesting part. So starting with his motor, he's weak in his upper extremities compared to his lower extremities. And then more specifically in his upper extremities, his hands are weaker than his forearms that are weaker than his biceps, triceps, and shoulders area. Sensation-wise, so he has a loss of pain and temperature, but a normal light touch. And then his proprioception and vibration also would be normal if we had tested that. Reflexes, he's hyperreflexic. He's got a positive clonus, meaning that as you tap on his reflex, he has sustained muscle contraction. And then he's got a positive Babinski sign. So as you fan the bottom of his foot, he has an upward dorsiflexion with fanning out of his toes when his foot is stimulated. And then the final thing is he had some bladder dysfunction. So in our case specifically, he had some urinary retention, but you can also get some urgency as well. So thoughts on what this diagnosis could be? This is called central cord syndrome. So central cord syndrome is the most common incomplete spinal cord injury. It most often occurs in hyperextension injuries. So like our patient here, slipped, fell, hit his chin on a table and kind of hyperextended his neck up. What happens is you get a compression of the gray matter in the central aspect of your spinal cord, and this can cause reduced blood flow, leading to ischemia. And, before we get all freaked out that this is going to happen to any one of us next time we have a fall, usually this happens to individuals with some sort of preexisting cervical stenosis or some sort of degenerative changes in their cervical spine. The reason why I think this case is so interesting is because if you understand the anatomy, you can predict exactly what their physical exam findings are going to be. So if you look at a cross-section of the spinal canal and you kind of circle right in the middle of it, looking at that cross-section, and we'll have a little diagram in the show notes here. You have your descending and your ascending tracts, your descending being motor and your ascending being sensory. So as we look at our lateral corticospinal tracts, this is where our motor is. So as we work from outside to inside, we get more distal in the arm. So the hand is the most central part of the spinal canal, and then the forearm, and then the bicep, tricep, and then shoulder area. So it makes sense that the hand is the weakest because that is the more central aspect. Similarly, with our ascending tracts on the sensory side, in our dorsal column, which is in the very most posterior aspect, this is where our fine touch and our proprioception and our vibration are contained. And this is relatively spared in central cord syndrome because it happens so far dorsally, not centrally. In contrast to that, to our lateral spinal thalamic tracts, this is where we get our pain and temperature. So this is, again, more centralized. And then if we look at our reflexes, so this patient was hyperreflexic, meaning that we're getting a loss of inhibitory control from the brain. Similarly, same thing with the bladder dysfunction. So these patients get urinary retention and urgency because of this same damage to the corticospinal tract. And then finally, how do we explain our positive Babinski? So again, this is an upward dorsiflexion, fanning out of the toes as we scrape our tuning fork along the bottom of the foot. And usually this is indicative of an upper motor neuron injury, also of that same corticospinal tract. So back to our case here. So how do we diagnose this? Again, the money really is in the physical exam because our CAT scan and our CT angiography is going to be negative. So these patients, they all do need an MRI. Obviously, that is the gold standard of diagnosis. And in the time that they get there till they get their MRI, they really need to be strict C-spine. And then these patients need kind of neurogenic shock precautions. So we want to keep a MAP goal of 85 to 90 for the first 5 to 7 days after their spinal cord injury to really ensure that you're fully perfusing the center of that spinal canal. And then really having a low threshold for starting either some Levofed or Levofed plus phenylephrine, because we really need to maintain that perfusion of the center of the cord. And then, considering intubation for injuries that are above C5. And then ultimately, depending on how severe these are, these either go for decompression surgery or physical therapy. So our case specifically, this person ended up going for a decompression surgery. Unless I followed up on them, they had regained most of their strength except for a small little bit in their hands, which again makes sense based on the anatomy of the more centrally located neurons. So that's all for central cord syndrome. Just quick summary. Remember that your motor, you're going to be weaker in your upper compared to your lower, and then more specifically, weaker in the hands, then the forearms, then the biceps, then the shoulders. And you will have a loss of pain and temperature, but a normal light touch and vibration. And then you will often be hyperreflexic, and make sure you keep strict C-spine, neurogenic shock precautions with a MAP of 85 to 90, and likely they will need decompression surgery with neurosurgery. Thanks so much, guys. Have a good day.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.